Our other panelist is Dr. Dan Wohlfeiler, who is the co-founder of the Building Healthy Online Communities, a public-private partnership between dating sites and apps, HIV and STD prevention organizations.
Good afternoon, everybody. Thanks for inviting me. My name is Dan Wohlfeiler. I'd like to thank Dr. Boyer for giving me the honorary doctorate, but after all these years and now in semi-retirement, I still don't have one, much to my family's disappointment. I am currently a consultant at the San Francisco AIDS Foundation. Much of my work has been funded by Gilead Sciences. And what I want to do today is talk about the slides that are about to be on the screen. How about this one? There we go. Thank you. Even better, thanks. What I want to talk to you today is about our work at Building Healthy Online Communities, which is a consortium of public health organizations, some of you are in this room, to work in a coordinated fashion with dating apps primarily used by gay, bi, and trans men. And I want to start with three themes that really underlie our work at BHOC. The first is that we talk a lot about social determinants, and we ignore the fact that businesses in this world are one of the largest social determinants there is. We talk about poverty, we talk about racism, we talk about economic injustice, we talk about homophobia, but in contrast to nutrition, to tobacco, cancer prevention, and injury prevention, all of which engage with businesses that affect their respective cases and morbidity. STD and HIV prevention have largely ignored the impact of businesses, whether we're asking them for money, whether we're confronting them, or whether we're collaborating with them. And we've taken a deliberately collaborative approach. Second paradigm that underlies our work is the concept of having structural interventions, which are interventions that continue to have a positive effect, even if those of us in the room as service providers aren't anywhere near the people we need to reach. And about 20-something years ago, we held our first meeting on structural interventions for HIV prevention at the CDC, and a colleague Steve Terrett, who was running the Center for Law and the Public Health at Johns Hopkins, leaned back in his chair and he said in this sort of avuncular way, you all in HIV prevention are trying to do the hardest thing, which is to change people's behavior. We in injury prevention put banks in the curves of freeways so that as people are driving along, even if they're speeding, they don't injure themselves, they don't injure others. And I'd shown this slide probably 200 times before I noticed the sign in the back, which says, all you can eat, the impact of media. Third paradigm is probably one that's more familiar to all of you in the room, which is the whole concept of sexual networks. And face it, the internet is a network, that's why it exists, and we need to be able to address the way we can shape networks, work with networks, not simply use them as ways to find cases. So Building Healthy Online Communities, we have three goals. And the first is to build in those banked freeway curves, to build in those self-sustaining features into sites and apps that can both promote health and helping users make informed choices, which I'll talk a lot about today, and also help us reduce stigma, whether it's STD stigma or HIV stigma. The second is to coordinate and improve advertising and messaging. Can I just get a show of hands in the room of how many people have tried to place an ad anywhere as an ad, either online or offline, any advertising or messaging? This is more than average. Most of us in this room and the places we represent aren't trained in placing ads. We tend to not do a very good job at it, and we need to improve public health capacity to do so. And the third is to coordinate interactions with sites and apps. Typically what would happen for years is that California, for example, would go to a dating app and say, we want this. San Mateo County within California would say, we want that. New York would say something else. And the dating app owners had no clue as to which one of these made the most sense and what we should be doing. So we've been collecting data and working with all our partners to make much more coordinated approaches to the apps. Our public health and research partners, you can see online, they include the CDC, NASDAT, and NCSD, nonprofits, AIDS United, Project Inform is actually now defunct, and so this slide is almost also. San Francisco AIDS Foundation and YTH. And we work with researchers at University of Washington, Johns Hopkins, and Emory to collect data on what users actually want and what's likely to be the most popular on the apps. Our website and app partners, you can see a broad range of them. Some of them are very broad-based. Adam for Adam, for example, reaches men of all colors, men of all ages. Daddy Hunt is not for guys under 18 who are seeking daddies. It's for men of different generations who want to have relationships with each other. BarebackRT.com is for guys who never wanted to use condoms. Grindr is obviously the biggest, and you can see others on the screen. And Growler, if you don't know it, is for what are called bears, bigger, furrier men. And I should also note that Sean here is now the chairman of the board of Hornet, which is one of the apps that we've worked with. So I want to talk about how we get stakeholder input and feedback into which interventions are going to be the most promising in terms of user uptake. We did a survey back in 2009 when apps were just beginning, and most of these were dating sites that you would access on your computers, not on your mobile phones. And we came up with a list of 41 different interventions you could do online. Some of these were things that we'd all been doing in other areas of HIV and STD prevention, such as adapting street outreach to online work, doing partner notification. We also had ideas that weren't currently being implemented. And what we did is we gave that same list of 41 interventions to website owners and managers, which I have to say, for those of you who have tried to reach the hard-to-reach populations, probably took the most work to get 18 of them to answer the survey. We surveyed 82 HIV and STD directors, and we had completed surveys from 3,000 website users who are all NASEM. And we've continued our collection of data. This is from 2017. I'm not going to go through this whole list. The red bar indicates the users who would like an app to add this feature, and the black bar is users who would not like an app to add this feature. And what you can see is more than 50% wanted all of the interventions that we came up with, except for daily reminders to take their HIV meds, which I believe is a result of that fewer users were in fact HIV positive. But these range from getting alerts about disease outbreaks in their area to having a live chat function with a sexual health counselor. So the activities we've been taking on since we did our first survey, and then we continue to refine the activities as we get more data, are the following. One is to make personal profile options the more explicit, the better. To offer automatic HIV testing reminders at a user's choice of interval. And just an anecdote about this, when we were first doing focus groups to shape what the national survey would look like, we asked guys, how many of you want a reminder from Manhunt at the time, or Adam for Adam, to get tested? And no hands went up. And we said, what if you could control the interval at which you got the message? And hands shot up, and when we did the national survey, that turned out to be one of the more popular ones. The take-home message we got is the more people feel in control of what the email or the reminders are, the better. If you can control the technology rather than just get bombarded with spam, all the better. We had several of the owners, when we met with them, say, there's no one place I can refer users to get comprehensive sexual health information for MSM. You have to go to 20 different sites. Some of it is gay friendly, some of it isn't, some of it's medically accurate, some of it isn't, and some of it's up to date, and some of it isn't. So we spent a lot of time developing this language, and we have everything from what is good sex to what are good STD tests, and what does a complete checkup look like. And we make that available to anybody who wants it, whether they're HIV and STD organizations or the app owners themselves. So if you don't want to come up with your own copy, feel free to use ours. It's not considered stealing or borrowing, just use it. The next is to coordinate ad design and placement. Next is what we've been doing is promoting best practices, what to do and what not to do. And then developing better practices also around online partner notification. I'll talk about some of the interventions we have in DIS training, and to figure out ways to reduce stigma online. I'd like to say that gay men treat each other better than people do on any other social media, but in fact, if you go on any of the apps, you'll see a lot of insulting behavior, whether you're too fat or too femme, or you're a different ethnicity that I want to have sex with. You see lots of stigmatizing behavior. We've been working with researchers at Yale who have really sort of shown the impact of in-group stigmatization on mental health and therefore sexual health, and we're trying to combat that. So the first intervention, one of the most important, is to help people make informed choices about their partners by having much more specific information about their own health practices and those of their partners. The next couple screenshots are from Grindr if you've never been on it. And we were able to work with them to incorporate HIV status, and you can see the range of choices, the last tested date, and we're trying to work with them to make it really clear this isn't just HIV testing, but also STDs as well. And they've also got a sexual health FAQ. We were able to implement with them testing reminders, again at the user's choice, whether 3 months or 6 months, and we give users information, or they give users information on how to make the decision, whether they should be getting it at a different interval. They've developed a sexual health resource center, and as you can see, they've gotten more than 16 million viewers, unique viewers since November of 2016, and you can see the leading countries, US and United Kingdom at the top. And they have copies such as, what should I ask for to make sure I'm getting the most complete STD test? And sometimes they come up with their own copy and give it to us to review. Other times we help them come up with the language from the beginning. So we've worked with a number of apps to implement these structural features, and you can see the list of them. I would say Atom for Atom, Daddy Hunt, Grindr, and Growler we've probably had the most direct impact on. Hornet and Scruff developed many of the strategies you see of their own accord, and we continue to work with the apps to refine the language. We used to think, for example, that if an app just said PrEP and gave an option of a user checking PrEP, that would be enough, but what we've learned is that sometimes you don't know if a user puts that, if it means I'm on PrEP, I want you to be on PrEP, PrEP should be in the water, PrEP's a good idea. We simply don't know. So we're working with the apps to have first person language, I'm on PrEP, I'm undetectable, I'm open to using condoms. You can see that some of the exceptions are Growler does not offer testing reminders, we hope they do. Grindr and Hornet are not currently having profile options that say I'm open to using condoms, and Scruff does not yet have HIV status and testing reminders. We continue to have dialogues with all of the apps and hope that they'll implement all of them. Okay. For those of you who remember InSpot, which was a way of notifying your partners anonymously that they should get tested because either you've gotten diagnosed with an STD or you think for whatever reason they should, and you don't know which way the infection or transmission may have happened, InSpot allowed you to email somebody else that you wanted to make sure anonymously found out and you weren't comfortable for whatever reason disclosing your own name. But email is now so 2000. And what we've done is updated it with their full support and collaboration to allow people to send texts as well. And you can see either an email or a text. You can notify them that they should get tested for any one of a number of diseases and infections. You can notify up to 5 people. One big concern is that people will send these messages to somebody who stood them up on a date or somehow managed to anger them in some other way, or you're just doing it as a practical joke. From looking at the experience of InSpot and similar programs in Australia, it rarely happens. And we limit the number of contacts you can contact at once to 5. We've also developed toolkitsimulator.org, which is to train DIS on how to work online. And many DIS have never been on an app themselves, so we teach them everything, just what do apps look like, how do people work on them, and give them skills to work more effectively online. We're also developing a national home testing program, and this really plays right off of what Ina was emphasizing. We know that apps can reach users who haven't been tested regularly and recently, and we know from our own data that more than 3/4 of users want apps to make free home test kits available. These programs already exist, home test programs in Virginia, Arizona, and New York City, and they've been quite successful. We've been talking to apps about how can they support this and how can they do advertising for this and support our programs and make it more available. Our pilot program is going to begin in March. Grindr is already supporting this effort, and we anticipate that others will as well. We've been collaborating with programs that probably a lot of you are familiar with at Emory and working with NASEM as well. Right now, the home testing program is going to be for HIV, but we anticipate this will be expanded to STDs. For more information about any of our programs, you can go to bhocpartners.org. We've got information for app owners, for public health and researchers, and importantly, the user info page, which is the sexual health compendium, as well as information on how to help users notify partners. One of the key areas we've been working on, since so many of us know about advertising and many of us don't have good advertising ourselves to present, is to develop both the Safe Sex Compendium, let's go back here, and we've been developing a advertising clearinghouse. This is just a screenshot. And I have to say that one of the hardest things we've done is to go to health departments around the country and to CBOs and say, do you have an ad that another agency can borrow, that they can use, they can just change the destination of where you want to drive people? It's been worse than pulling teeth, and I've had several teeth pulled. And I'm getting another one January 2nd in case anybody's interested, which you're probably not. So we've been working with NASEM and NCSD to go to all of their members and to a number of CBOs collecting these ads. And the idea is that none of us probably have the skills to do it well. There are certain campaigns that are very effective. And frankly, the biggest change that we see from one ad to another isn't necessarily the creative itself, but how much money do you have to spend on actually getting the ads out there? And for every dollar that we're not spending on creative, we have that dollar to spend on placement. We worked with Daddy Hunt, which we've been working with them on a number of questions about apps, about profile options and testing reminders. And they did a marketing video 3 or 4 years ago that simply showed the viability of an intergenerational relationship. The guy on the right, incidentally, was the latest cowboy in the Village People. And it simply had a cute love story. Based on that, we decided to collaborate in doing a second and a third series. In the second series, the older guy wants to use condoms, the younger guy wants to use PrEP. I'm happy to report that they work it out just fine. In the third series, which we did because the second one was so successful, there's much more information and plot lines around having an undetectable viral load and what does that mean. Since we had all the actors in one room and on set, we also developed a number of public service announcements which range in topics from what does it mean to be undetectable to how does partner notification work, what's a good STD test. All of these are open license, which means anybody can use them anywhere. One of the last interventions I just want to talk about is niceaf.org. My nephew asked me if I knew what AF meant, and I was happy to report that I did, even though I'm 3 times his age. And what we're trying to do is get users to submit ways they have of combating stigma online. This is still in the pilot phase, but I have to say it's one of the first interventions that we've gotten all five of the larger sites to say, we want to participate, we want to promote this as soon as we figure out how to tweak it in such a way that it'll be more successful. Quickly, I want to go over my wish list, similar to Ina's wish list. Jeff, you might remember this from 1999. This was there were 2 act-ups in San Francisco for a while, one legit, one not so legit, and this was a campaign that the illegitimate act-up had. that was protesting the emphasis on syphilis and saying syphilis scare is an anti-gay lie. 4 cases are not an outbreak. Wouldn't we love to have only 4 cases now? But I've spent lots of time with Gail Boland and others trying to come up with what's the best definition of an outbreak that we can use. For example, if we want to go to a dating app and say, there's a serious outbreak, we need to do something. Is that the number of cases? Is it the higher rates? Is it the severity of disease? To simply say there's an outbreak isn't going to do it. I can't think of an intervention that's gotten less promotion than partner services. So it shouldn't be a big surprise when someone calls up from the health department and tries to get somebody on the phone. They have no idea what you're offering, no idea if you should trust it. We produced one PSA that promotes partner services, but there's a lot more. I've seen no data, or almost no data, on how many people notify their partners without any help. I see them over time, and if I can beg for another 2 minutes, I'd be grateful. Thank you. So we need a lot. We don't know when people aren't talking to DIS, how many of them have already talked to their partner themselves. We need to scale up our interventions considerably. In 1984, Les Pappas, who would probably giggle if I told him I'm still quoting him, said we need to be competing with Madonna and in terms of the scale of interventions that we have to offer and the advertising we have to offer. My response then and my response now is on a really good day, we're trying to compete with the Kingston Trio. The question I've got for all of us is how can we know if our interventions are failing and rates are going up because they're just not effective or because our interventions just aren't big enough? And the most, let me just start with saying that a year ago, somebody we work with made us some tagine, a Moroccan dish with some terrific spices and chicken. And the next day I was thinking about our work and I was thinking about how good the tagine was last night. And I realized the way I sort of think of much of our efforts in terms of the resources that we have is we need to have tagine ready to serve 1,000 people. We've got enough to serve 1, and we spend a year trying to figure out should we use half a teaspoon or an entire teaspoon of salt. The level of resources we have to compare to what we actually need to accomplish to bring rates down is minimal. So I just want to end with the last of the list. One is we need a lot more guidance from CDC and from others about how to do good advertising. We all need to get much better at sharing ads and provide guidance regarding online buys. We need much better data and guidelines about should we be doing outreach at all. I've seen no evidence that suggests it's particularly effective, yet a lot of people are doing it online. We need to be getting much better to be able to improve our targeting, figuring out which apps are people who have syphilis reporting, where are they reporting meeting partners. Doesn't mean that's the place where they necessarily came into contact with the infection, but it may be where they're meeting partners. We need to support online home testing distribution networks, and we need to convert the very good site gettested.cdc.gov into a one-stop shop sexual health portal. Whether you're looking for PrEP or you're looking for an STD test or an HIV test, there should be one. I want to end by thanking all of my colleagues who you can see here, and I think we're available for questions at this point. Thank you.